great join Randy today. Randy, in addition to all of the titles that Heather shared, is on the National Advisory Committee for the INQRI program. So I always enjoy, even if we're having to do it virtually, the chance to spend an hour or so with him. I'm really excited to welcome all of you and to join Heather and Mark Pauly, who's the co-director for the INQRI program, as part of our series to really focus on the issue of research translation. And Ray and I had the opportunity, along with our respective teams, to get pretty knee-deep into this for a couple of years together. So we thought we would share with you a little bit about the experience. But to start off, Heather, first slide. I wanted to make sure that everyone on the phone had an understanding of the world in which we've been working, this area called transitional care. It's actually a concept that was introduced here at Penn many years ago by Dottie Bruton, who was taking a look at the very long lengths of stay of very low birth weight infants and thought there must be a better mechanism that would allow earlier hospital discharge and still excellent care and outcomes of this population. And so when I came to Penn, having worked with the Senate Committee on Aging, where a policy had been introduced, the prospective payment system for hospitals that effectively and dramatically shortened lengths of hospital stay, we began to think about maybe this same concept, which in one era was used to shorten lengths of stay, might be an important bridge when we have had that imposed upon us to provide a safety net for populations. And this was fueled, by the way, by increasing anecdotal evidence of higher rehospitalization rates among the Medicare beneficiaries. So the American Geriatric Society talks about transitional care as a range of time-limited services designed explicitly to complement and supplement primary care to ensure healthcare continuity, avoid preventable poor outcomes, targeting at-risk patient groups as they move from one level of care, such as acute to post-acute, or among multiple providers and across settings. Next slide. The opportunity a couple of years ago to work on a National Quality Forum Steering Committee that began to think about how can we position ourselves as a system to have our system more aligned with the needs of people as they move across an acute episode. The acute episode for patients and for family caregivers is not hospital admission to hospital discharge. It's that acute phase that may span movement through a post-acute rehab environment and back to secondary prevention, often to their homes. We recognize that even among the Medicare population that not everybody moves along that trajectory in the same way. So we have individuals that are relatively healthy and for whom that movement is relatively uneventful, and we expect that they'll return to pretty positive outcomes in short term. But our team has focused on these latter two groups, adults with multiple chronic conditions and increasingly adults at end of life. Next slide. Before I get into talking a little bit about our work, and even though I was recently introduced as the grandmother of transitional care, and we've certainly been at it a pretty long time with the great, terrific multidisciplinary team here at Penn, I wanted to share a little bit of what's happening in this field and kind of to distinguish the directions that different scholars and health services researchers are taking in terms of transitional care interventions. Increasingly, we're seeing a number of efforts that are directed at closing the gaps between hospital and next site of care and promoting effective, in the vernacular of the day, handoffs. And so when you think about this, Brian Jack's work in Boston, where he worked toward re-engineering the discharge planning process, demonstrated the capacity of that kind of approach to have short-term reduction in hospital readmission. He saw 30-day readmission with that. Eric Coleman has used a coaching model, nurses who are coaching patients and family caregivers, and along with a personal health record, medication reconciliation, but real focus on that handoff has demonstrated also 90-day reductions in hospital readmissions all cause, with a focus on the short-term handoff. So our team actually started that way about 20 years ago. We initially had an intervention that's similar to Brian Jack's, focused on improving the discharge planning process and the actual handoff, and we demonstrated even at that time a short-term reduction in hospital readmission. But it really began because of use of a mixed methods, qualitative and quantitative, to focus in on a high-risk population that wasn't doing as well as others with just that approach to care, and felt, one, that we needed to have an approach that spanned hospital to home and sometimes through intermediary post-acute sites, but also that took advantage of an acute episode of care as a sentinel event to try to achieve longer-term outcomes. And so our work has really been about how do you capitalize on this sentinel event to address root causes of poor outcomes and to aim toward achieving longer-term outcomes. Next slide. So we've been talking about, we are talking about the quality cost transitional care model. And the hallmarks of the model are focus on high-risk screening, engaging older adults and caregivers, placing a premium on getting their plan of care right, rational, streamlined plan of care, managing their symptoms, and then ultimately positioning patients and their family caregivers to be able to early identify when they're running into trouble and to know what to do in response. And it places a premium on some of the core principles that we learned in nursing and medicine and social work 101. Collaboration is key. Continuity of care is critically important for people who are navigating healthcare systems, especially in these days, care coordination, and all of it fundamentally built on a high trusting relationship. Next slide. So unique features of our model is that the care is both delivered and coordinated by the same master's prepared nurse who is working with patients from hospital admission, in the hospitals, in skilled nursing facilities, and the same nurse working with these patients in their respective homes. It incorporates 7-day per week availability. The average intervention in our clinical trials has extended from hospital admission to 2 months. It relies very much on the use of an evidence-based protocol. We've learned over these 20 years through our detailed case studies and through our quantitative work the kinds of things that people experience at each data point. We know what causes things to go wrong while patients are hospitalized, which is why the role of the nurse in the hospital is exceedingly important. We know what happens within 24 to 40 hours after hospital discharge that might plant the seeds of readmission. We know that 2 weeks later after hospital discharge that all patients are at a low ebb functionally and physically, et cetera. So we have an evidence-based protocol that is guiding the work of these nurses, which they obviously highly customize and individualize. And once again, focus on the long-term outcomes. Next slide. So in terms of, we've had a great investment from the National Institute of Health in the over these uninterrupted funding over these years, National Institute of Nursing Research, National Institute, and more recently the National Institute of Aging. Next slide. And what we've learned across all of the clinical trials completed to date is that the transitional care model, relative to standard care in multiple sites, increases time to first readmission or death, improves physical function, and in our most recent completed trial, improved quality of life, decreases total all-cause readmissions, increases patient satisfaction, not surprisingly, and after taking into account all the cost of the intervention and measuring all of the cost of the health services utilized by the intervention group compared to the control group, we demonstrated significant reductions in total health care costs. Next slide. In this slide, I'm showing you where, at least in 3 of our completed trials, we've shown reductions in readmissions, again, in the first trial at 6 weeks, close to 60% reduction, 50% at 26 weeks, and by in our most recent the trial at 52 weeks, a substantial reduction, significant reduction compared to controls, in this case for patients with heart failure. Next slide. And then the total impact on healthcare cost, and we're showing at the bottom of this slide when we measured in one trial, testing this with patients with a range of medical and surgical common reasons for hospitalizations of Medicare beneficiaries, a cost savings in the neighborhood of about $3,000. And when we extended the intervention to include for a 1-year follow-up in another trial, demonstrated savings of $1,000 per Medicare beneficiary. Next slide. So given the context in which we are operating these days, one would have thought, well, this is an easy sell. I mean, this is an intervention that not only does good, we quality outcomes, makes people feel better about their experience. We see improvements in patient satisfaction, but it also achieves the goal of bending that cost curve. We see reductions in healthcare resource utilization and associated costs. But what we quickly learned are that there are barriers to widespread adoption, one of which, of course, is the current organization of our care system, in which care is organized in silos. We talk about care that happens in hospitals, in the post-acute segment, in the skilled nursing facility segment, et cetera. And that's where all of the incentives are focused on those silos. So we measure quality in terms of hospital care, we reimburse hospital care, and so on. There are regulatory barriers. As I mentioned, we don't have the quality and financial incentives that really enable us or position us to think about care that occurs across multiple settings and that is closely aligned with patients' needs. And ultimately, this really approach flies in the face of still today, although I think this is very much changing, the culture of care. A care system that is very much focused on acute illness, a care system that's very much focused on provision of services by traditional single providers, et cetera, that is not longitudinal in nature. I think we're seeing movement, but I will say that the culture of care has been a barrier over years in our efforts to try to bring our work to have an immediate impact on clinical practice, on patient care, on patient and family caregivers' needs, and on systems outcomes. Next slide. So I guess it's about 5 or 6 years ago, we began an effort to think about what could we do as a team, as a research team, to really promote transition of research into practice. And there are wonderful stories about that, but it was our great good fortune to form a partnership initially with Aetna Corporation and subsequently with Kaiser Permanente to test real-world application of the research-based model for high-risk elders. And I wanted to acknowledge that this effort has been supported by a number of foundations and as well as the Commonwealth Fund. Next slide. We have been guided throughout this effort. One of the great ideas that Randy and I received as the team leaders of this effort was to bring on to our advisory group all representatives of all of the groups that we would ultimately want to influence. If we were successful in actually replicating what we'd achieved in the clinical trials, successful in translating our science into practice, that we would want all of the people around the table guiding us through this process who might ultimately be in a position to advance it. So we had representatives from CMS, we had representatives from advocacy groups, leaders of other purchasers, payers, health systems, etc. Now, Randy, take it away.
Thank you very much, Mary. So it was our pleasure to work with and develop a partnership with Mary Naylor and her team, and the purpose was to the concept of transitional care in a defined market, and that in this case our own market. We selected the Medicare population as an appropriate population for testing, and that is a population with a large number of admissions, a large number of avoidable admissions, and a large number of readmissions that we feel could be ameliorated. So we identified the barriers that we needed to overcome and the type of organization we needed to put together in order to try and implement within our own structure. So we developed a national advisory committee, which Mary described, and we developed joint teams to identify members, to better manage them, and to manage them together so that we could achieve results within our existing structure. And there are significant differences between what we're doing here and what you might see in an unmanaged Medicare population. Slide, please. We developed tools for screening patients. The problem here is that we have knowledge of who's an inpatient, and we have some knowledge of what they're there for. We have some occasionally pre-knowledge of the case, and we have to be able to identify who is an appropriate patient or member for recruitment into the program. We developed training for our team and for Mary's team to be able to work with each other on a coordinated program between our case management and the transitional managers of the advanced practice nurse. And adapted Mary's quality monitoring and information system to the purpose of this trial. And we had frequent meetings and frequent touch points with each other to discuss, one, how the program was working, what modifications had to be made, two, touch points with the case managers and the advanced practice nurses to improve their ability to work together. And we are looking to evaluate not just the impact, but the ability to implement programs like this on a wider scale. Next slide, please. The key decision points are going to be linking our own case management capability with a home care agency that can administer the transitional care program. So we targeted 200 members in the Mid-Atlantic region, which is metropolitan Philadelphia, who met criteria that we considered Medicare members who were susceptible to unsuccessful discharges, or who could benefit from better transitional care management. And we clearly defined the work roles and processes in advance to enable our teams to work together. Next slide, please. Indicators of success would be, well, a decision by our own organization that we're going to adopt this on a larger scale. We had planned to disseminate this information, and wider scale adoption of this program by other peers or employer groups would also be evidence of success. And the use of these findings by at a policy level by CMS or other organizations, that this is an appropriate activity that should be reimbursed as an appropriate model to adopt on a larger scale. Next slide, please. Here we have our how we're going to look at this, and that is value is proportional to what the quality or satisfaction or the delta that you are trying to measure divided by the resource utilization or cost, which is basically a mathematical expression for bang for the buck. Now the problem is we were quite convinced that this model is effective in an unmanaged population, that it can improve quality and reduce costs in a Medicare population, particularly a high-risk Medicare population. We had a somewhat different situation when we're looking at whether or not we should adopt it, and that is our members are under rather extensive case management. In fact, we manage about 17% of our entire population, which population that represents about 85% of our total acute inpatient days. So we have a population that's already under rather extensive management, and in fact, our acute days are about at the point the study was done, we're 26% below unmanaged Medicare, and that's with risk adjustment. And the question is, are we doing something comparable to the transitional care program, something different, something incremental? And that is, if we added transitional care program to our existing case management program, is it duplicative, or is there in fact incremental benefit? We're very careful to coordinate our activities between our case managers and the advanced practice nurses so they don't step on each other's toes, and we still had a single point of contact program, but we did not really know if we would have the kind of incremental benefit that we were looking for. Next slide, please. We've weighted several parameters that were important to us, which included the self-reported health status, the symptom status, for which we did see a significant improvement, depression, functional status, and quality of life. Next slide, please. And we did see overall a very high satisfaction from members, and which is not the least bit surprising. Also a rather high level of satisfaction amongst physicians, which is something we don't necessarily always see. Sometimes they view us as a hassle factor rather than someone who's helping them, and then clearly in this case, they viewed this program as helpful to them. Next slide, please. We employed a quasi-experimental design, and that is each member was matched with a control, and the controls were matched clinically. They were matched in terms of age, sex, and clinical risk level. And 155 pairs were identified using these criteria, and we used our own process and claims data to identify these and to follow these over time, and we are looking for impact both in terms of cost and quality. Next slide, please. We in fact saw a significant reduction in readmission rates and hospital days for the first 3 months. And this is precisely what we're looking for, and that is about a 20 to 25% reduction in 3-month readmissions for this population. This population, one that had already been under rather aggressive case management, and we got a significant incremental effect through this program. So clearly what we were doing here was not duplicative. It was something that was incremental, and it proved to be beneficial in the context of a rather well-managed population by industry standards. We also reduced skilled nursing admissions for the transitional care managed members that was not at this level significant, and decreased use of home visits likewise. Next slide, please. This was associated, not surprisingly, with significant savings, again, compared to the reference group, both at 3 months and at 12 months for the population studied. Not surprisingly, if 40 to 45% of the total cost of a typical Medicare population is acute inpatient, in this particular population, you're dealing with more than a random risk level, so the inpatient cost of this population would be considerably greater than 40%. So a 25% reduction in readmissions and a trend that decreases in other areas can so significantly reduce your costs, and this reduction in cost was likewise statistically significant. So we are in fact operating at what we would call the intersection between cost and quality. That is, these reduction in acute days are not denied days. These are days that didn't happen, which in my opinion represents the greatest intersection between cost and quality. Next slide, please. Item to comment on includes that the hospital component of the transitional care program was not implemented here, and that is normally the advanced practice nurses visit the members in the hospital prior to discharge and then post-discharge in the home to assist in a successful discharge. We were not able to implement the hospital component of this model, so we were missing a component. There likely was some incremental value in this component, which we really can't measure except by supposition, except to say that even without this component, this program was quite effective. And there are regional variations in service use between regions, which creates some difficulty in deciding where it can be implemented and what one might expect. So, for example, in the Mid-Atlantic region, we run relatively high acute utilization compared to some other regions. with lower utilization. That creates greater opportunity for a trial, but perhaps a little bit less opportunity when it's implemented on a larger scale. Next slide, please. So basically, we demonstrated quality improvement, we have demonstrated satisfaction, and we have demonstrated reduction in acute utilization without denials. So this appears to be a high value proposition to an organization such as Aetna, particularly for our Medicare Advantage program. We would judge this as successful, and one in which that we would expect to implement on a larger scale. And in fact, it is now in our strategic plan to implement this wherever we find sufficient concentration of members to make implementation possible. I think I turn it back over to you, Mary.
Great. Thanks so much, Randy.
Thank
you. So I wanted to tell you that as part of this project, we were obviously very excited about this opportunity to have this partnership, the research and real-world practice partnership, and we also took advantage of it to think about how we might help others who were interested in this world of translation. So part of the project was to hire an independent consultant who would conduct a qualitative component, and specifically individual who is really skilled in organizational behaviors, who conducted semi-structured interviews with all of our team members. And at this point, we're talking about a team that's Aetna and Penn working together during the startup phase. And they also, this interviewer and a postdoc also completed similar interviews with all of the players involved at the completion of the rollout phase, and this included the nurses and case managers at that point in time. So an analysis of the transcripts was conducted to identify the barriers and facilitators, and in the next slide, you'll see some of the key lessons. And honestly, I don't think any of these will be shocking to you. Consistently, the presence of strong champions was mentioned. Randy and I, we have actually a paper, and we're happy to put that on the website published. You know, we decided that we were, we're very honest people anyway, but this was an enormous amount of work, and I don't think that Randy or I or any of the team members anticipated, you know, what it was going to take to get two organizations that have real strong commitment to the same goals and values, but different cultures, different ways of working together, et cetera, to have this happen. And so we learned that strong champions to get through those rough spots are really, really important to keep people excited and motivated and focused on the big prize. The fit of the innovation, the importance of the business case, although I have to say in this case, I remember, Randy, our first meeting, prepared to sell this to you, and you said, I get it. So I don't know. I mean, but to have the evidence about the quality and cost impact of this, I think, was important to be able to make the case. The fact that this, you know, kind of innovation certainly is responsive to a very changing, very dynamic external climate. We learned the critical importance of total engagement. We made some mistakes in the beginning where we weren't totally engaging some of the frontline providers, and how important it was to be able to step back and reconsider this. We hosted some lunches and all of that to make sure that we really didn't make some of the mistakes going forward that we had made in the early stage. To being flexible, there are a number of issues where I can't tell you the nimbleness of Aetna in responding to some of what we had hoped and thought we needed in order to make sure the core components of the intervention were achieved, and equally we had to adapt and be responsive to what were some of the real issues and needs on the part of Aetna. To have clearly defined work processes and roles, and above all, really excellent communication. We were extraordinarily fortunate to have both clinical leadership, but in both projects, dimensions of the project that really talked to each other, connected with each other, and that really helped us again. Next slide. In terms of giving you a sense of where we are, as Ray has mentioned, This has been identified as a high-value proposition and expansion proposed as part of their strategic plan. We also have a rollout of the model going on in a translational research way with Kaiser, where we've implemented the model in 3 different hospital sites using different nurse staffing models, and the analysis of that work is ongoing. The University of Pennsylvania Health System has adopted transitional care model as a service line, and initially we have Blue Cross Blue Cross is reimbursing. We hope to have other insurers as well. We're working with some of the quality improvement organizations and other healthcare systems and healthcare plans to help them in our road to try to promote wider spread adoption. Next slide. In terms of ongoing efforts, we are completing a clinical trial. We've actually finished enrollment and are now in the analysis phase, in which we have, with NIA support, tested the application of the transitional care model with cognitively impaired hospitalized elders. Heretofore, the clinical trials have been with high-risk chronically ill people, but who've been cognitively intact. So this is helping us to expand our knowledge. We also have an ongoing study that's helping position us to test application of the transitional care model between the acute and long-term care sector. In terms of promoting widespread adoption, we can talk a little bit more about those efforts, but one of the things that I did want to highlight in terms of policy changes is that we have were successful in collaboration with many, including AARP, to have the Medicare Transitional Care Act introduced in the House and companion bills in the Senate that are modeled exactly on the work that's been completed here at Penn. And while we may have great hopes, I don't know what our hopes are these days in terms of healthcare reform, which in and of itself has many provisions in both House and Senate bills related to transitional care. I absolutely feel that we will be soon positioned with incentives and maybe in some cases disincentives that will create a very ripe environment for evidence-based approaches such as this. Next slide. So I really want to acknowledge our own team, the nurses and all the staff, both at Penn and Aetna, our transition center, our great translational partners, and most especially Randy and his leadership, and all of our funders. And you'll see on this slide, we do have a website where additional information on the transitional care model is available for each of you. And next slide. So we just really want to thank you for this opportunity. And Heather, at this point, both Ray and I would welcome any comments or questions. Floor, phones are yours.
Absolutely, and the phone lines are open, so everybody's unmuted, and we can also accept questions via the chat. So please feel free to share your questions and comments.
This is Laura. I'm hoping I'm okay. Can you talk a little bit more about the transactional care model as a...
So you broke up. I didn't hear the question. Can you repeat it?
What did you mean when you said the transitional care model is adopted at Penn as a service model?
Okay, terrific. So the home care division of Penn Home Care and Hospice, now offers transitional care services to Medicare beneficiaries who meet our risk threshold. We help them to establish this service line. And we're actually working in partnership with the home care division, based on all the lessons that we've learned from our work with Aetna, for example. We have participated in the training and in the recruitment and preparation of these advanced practice nurses. They are reimbursed currently by a local insurer at a case rate for the services that they're providing. The Penn team continues to provide the quality monitoring as well as quality improvement activities. We host weekly case conferences that allow these nurses to continue to grow and develop. But in essence, what we have now done is been able to move from a research to research translation to actual adoption by health system as part of their delivery services. So there's a line in home care, special product line within home care, transitional care services for high-risk Medicare beneficiaries.
Well, thank you.
Mary, questions that have come in via the chat feature. The first one is Susie Beck, and she asks, are the advanced practice nurses nurse practitioners or master's prepared nurses or clinical nurse leaders?
So hi, Susie. The advanced practice nurses in the clinical trials are master's prepared nurses who could be clinical specialists, nurse practitioners, or combination. So we are mainly interested in individuals who have more of the competencies and expertise, advanced knowledge and skills in the care high-risk populations, real strong demonstrated evidence of strong collaboration with physicians. I mean, these are nurses that are at hospital admission, reaching out to the physicians and all the physicians involved in a patient's care, including the primary care physician, the same nurses that are going to on the first visit to the patient's physician to establish collaborative relationships. So the educational preparation is master's preparation, but not earmarked specifically for nurse practitioner or clinical nurse specialist, really focused on the knowledge and skills that they bring to this population. Hey, Randy, how about you take the next one? What do you see as the role of emerging technologies, electronic health records, telehealth?
Well, there are several roles here. One is to help identify members or patients for this and other types of interventions, but the other would be to improve coordination between the components of the healthcare system. So, for example, we could, if information can be shared between physicians, hospitals, advanced practice nurses, case managers, and other components of the healthcare system, the ability for us and case managers and advanced practice nurses to accomplish coordination would be vastly improved, and there's quite a bit of opportunity here. In addition, there is also the opportunity to identify and detect actionable gaps in care. For example, if you have medical information from various sources stored in a single point or available in a single point, you can scan it for actionable gaps in care. That is, tests that need to be done that haven't been done. Someone with post-MI who's with no record of a prescription filled for a beta blocker, for example, drug interactions that possibly even written by different physicians that are unaware of each other. There are numerous opportunities for care completion just by having multiple sources shared at a single point.
Do you think the next one was from Lynn?
Where is it?
Lynn asked how to get the idea to work with you, Randy, to work with Aetna. Did someone help me navigate the organization to find you? So Lynn, this is really telling a part of the Irma Bombeck story that I'm hoping someday to have a chance to write. I will tell you honestly that we had a number of failures before we found our path to Aetna. Our Office of Technology Transfer invested an enormous amount in us in our early years. They were of the mind that our work and the science that we produced was the equivalent of some of what they used to promote new businesses with, and so began to work with us to think about what might be the right business arrangement. There was even a huge investment by Penn in creation of a small business and so on. And before we could actually get the business off the ground, we'd actually recruited a president. He was recruited by another venture capitalist, and so our business failed before it even started. So anyway, we strategized as a team to think about who out there would get this and for what type of organization would understand and have the shared vision about an innovation that could improve the quality of care to people that they served and hopefully achieve added value to the work that they were doing. And at the time, Jack Rowe, a geriatrician, was president of Aetna. And so there was a dinner. I tell this story, and he doesn't remember it at all. There was a dinner, and Mark Pauly, who is a healthcare economist, works with us, Randy and I, on our respective work, here at Penn, and so I think I got myself situated to be able to sit down next to him and tell the story, make the case. He probably had more than he asked for that evening, but honestly, within a week or two, he put me in touch with Randy, and things moved very quickly from the standpoint of, making the case. From that point on, I wouldn't say that the project moved very quickly, but from the standpoint of just building the partnership and positioning ourselves to think about how this would happen, it was greatly facilitated by initially Jack and obviously by Randy. Did I miss anybody? Barbara, did you have your hands up?
No.
Okay, all right, good.
I have one more quick question. How did champions come about? I mean, who stepped up?
We talk about that? Randy stepped up. Let me give you some examples of what we confronted. At one point, there was a real question, even in our own university, about whether or not we were going to be taking too much risk. And so it actually had to go to, I think, the head of the legal team here to take a look at this project and whether or not, in their eyes and worldview, there was just too much risk to take. But I have to say, I think that Randy and I, because we really believed in it, helped to navigate some very difficult times. And in addition, the clinical leader champions like Maureen McCoy and Kathy McCauley really, really, really helped because of their commitment to high-quality patient care, et cetera, worked and navigated together some very, challenging moments during this. Your thoughts?
Absolutely. I mean, the fact that we had clinical teams, both Mary and I, that were absolutely committed to making this work because we were both convinced that there is value here, really largely made it work. And I can give you numerous roadblocks that we hit. For example, it has to be vetted by legal. There were problems with corporate practice of medicine. Not only could we not actually hire the advanced practice nurses, but if they're under contract to do care management, they can't do anything that looks like a skilled need. They can't put a stethoscope to his chest, and in the first iteration, they couldn't take a blood pressure, they couldn't do a pulse, they couldn't do anything that a nurse can do for not what's more an advanced practice nurse. So we had numerous issues to work through in implementing this, and it was easy, but we had a team of nurse clinicians, of project managers, and health economists, and I will even say lawyers.
Plenty of lawyers. Well, listen, can I tell Randy one of your favorite quotes? Of course, this came out after we had the organizational consultant interview, and so this quote came out, and it said, senior leader on the team said, "We didn't know what we didn't know," which I still think is really, we had no idea going in. I had no idea going into this about the complexity of our respective organizations, let alone sort of marrying the two in this project. And so maybe it was good that we didn't know what we didn't know, because we decided, the team, to kind of take each of these issues and deal with them. And I think the one thing that there was a sense of was that the team's commitment and spirit to problem solve. So it wasn't that we didn't have problems. We had problems aplenty, but a real sense that, we're going to do something here. And I think that really got us through some very, very difficult times. So now this is an interesting question. Do you think the level of case management in the study was mirroring the impact of in-hospital nurse interventions, hence the incremental benefits without having the part of the model, without having that part of the model implemented. So I don't know, Randy, how you would respond to that.
That's the only way to test that question is to do another study comparable to the one we've already done. I'll tell you, we get a 26% reduction without transitional care. On readmissions, we're getting an incremental 20 to 25% reduction. Now, that does not mean that we're all out of avoidable admissions here. We're clearly not. But as you go from the low-hanging fruit to the hard gravel road, it does in fact get harder, and the amount of work it takes to get to further increases. So I do believe that there is incremental value to the initial evaluation being done in the hospital. That there is some value, one, in a face-to-face as opposed to telephonic interaction in terms of depth of contact. And that's not to say that telephonic case management is not effective. It can be very effective. But I think the level of interaction can be improved, number one. And number two, the ability to coordinate the pre-discharge and post-discharge through a single person and a single point of contact have actual value. And I would say that there probably is some incremental value there. Then if I'm going to try and implement it within my system, I'm going to be asked to quantitate that, and that's going to be hard to do.
I would agree that is an empirical question. The only thing that I would say is that we have been able to track that many seeds of readmission are planted in the hospital. So some of the adverse events that might have started in a hospital and may not result in a hospital readmission for 3 or 4 weeks hence are things that we, at least in the clinical trial, we've been able to document. So while I agree it's an empirical question, outside of this particular initiative, we certainly believe that the role of the nurse in a hospital has been important, and in fact we've demonstrated a capacity to have an impact on preventing adverse events and promoting positive. The role of the nurse in the hospital is to work with pharmacists to streamline the medications, to work with the physical therapist, to develop a exercise plan, which we know from science, not science, but others, is critical in people who are really poorly deconditioned in order to prevent future rehospitalizations. I think there was a paper in JAGS just in the last couple of months around those relationships. So I apologize because I've been looking down at the bottom, so now I've got to go look at the top. And I think the next one is how do you envision TCM being rolled out in the Medicare population? Well, that's the fee-for-service population. And so in that respect, there's a lot of commonalities in terms of its actual rollout. In our work right now within New Jersey, with collaboration with the New Jersey Quality Improvement Organization and one hospital site that's involved in that effort in New Jersey, we're doing very similar things. The nurses are being trained and prepared in the same way, web-based training modules with individualized orientation to be able to really position them to be successful. Patients are being screened. So unless I'm missing something, I think the fundamental difference is simply, but so tell me if that's what you were, if I'm answering that question correct. If I'm answering your question. Well, I'm hoping I did. So let's see. Then Paul wants to know what part of the intervention was different from usual care. So I think this is a million-dollar question. People are always interested in multidimensional interventions to figure out, what are the core components. And we actually have work ongoing to help us uncover that, but we're not in a position right now to be able to know that for sure. It, again, is a really important question. Having said that, I certainly think that the continuity of care provided by the nurse, the fact that the patients and family caregivers have access to a point person, a broker of care across an entire episode, and have access 7 days per week is an exceedingly important dimension of this. I think the evidence that guides the work of the nurses, being able to have reliable performance of these nurses because they are guided by this a knowledge of what it is that they need to do within the first 24 hours, or at least what it is that they need to be concerned about, because we've identified in other trials that these issues or concerns are surfacing. I think a collaboration between the nurse, the patient, family caregiver, and the clinicians, and most especially, I think the work that we do at the beginning in having patients identify their health goals, family caregivers identify their goals, and use that as a path forward in order to measure our performance. But we do have studies in which we have nurses actually documenting problems and their interventions, et cetera, and I think that work, as we do the analysis around that, will help us be much more empirically based in responding to that question. Let's see. I'll make sure. Okay, so if a patient is admitted a second or third time during the 3 months post-discharge, does the same nurse follow the patient? And the answer is yes. Within the clinical trials, and now that this has been established as a service, the way that the service is unfolding is that the nature of the intervention, as I described it to you in the clinical trial, hospital admission, a couple months post-discharge continues. Additionally, the nurse continues to have monthly outreach with these patients, recognizing that these are high-risk patients, many of them on a downward physiologic trajectory. If a patient during the course of the follow-up is re-hospitalized, the nurse goes back in, doesn't stay in for the entire intensive, but tries to address whatever root causes, and we use root cause analysis as the basis for helping our staff grow and learn about their role and their capacity to influence and impact patient, family caregiver, and system outcomes in our work. So the same nurse will go back into the hospital. If on a call they identify that a patient, it's just on a routine call, seems to be in trouble or may be trouble, then they make a home visit. So the whole model is centered around patient and family goals, experiences, wishes, preferences, and a real understanding of a capacity of approaches of care like this to both improve quality and reduce readmissions. Okay.
Mary, it looks like we have one more.
One more question.
Would you elaborate on how APNs engage patients in self-management?
Really excellent question, Patrick. And so I actually started to answer that by saying that a hallmark of this, and a hallmark, I think, of any great care, is really starting with what the patient considers their goals, their health-related goals. So patients have identified to us that they want to be able to get to a great-granddaughter's wedding, that they want to be able to get to the casinos one more time. There was a story in the Washington Post that had a picture of one of our patients. It was standing in the garage doing woodworking, and prior to our engagement with them, meaning our nurses' engagement with them, this individual, Mr. Lind, he provided us with the opportunity to share his name, had been essentially homebound. He and his wife, 50 years together, lived very full life, but as a result of poor symptom management, he had been in and out of the hospital and had not literally been out of the first floor of his house. The picture, of course, was of him in the workshop. And so fundamental to this notion of self-work, self-management, is really getting what people's self-goals are. And family caregivers' goals. But then I think a lot of this has a lot to do with how to individualize care. So we've thought we've really spent a lot of time doing a lot of things wrong and some things right over the years. How do we position people with the things that they need to know, the things that they need to develop skills in, and so on? So in many cases, in many homes, we bring in an empty tape recorder, and the nurse will begin to reinforce some of what patients might have heard in the hospital but often don't retain. But the nature of the interaction with the patient is really around the things that are so important to them, what it is that they need to know about their diet, their exercise, about their coping strategies, and so on and so forth. The tape's left there so that the patient can play over and over again. Family caregivers can turn it on and add questions when they might have, so that in the next visit, nobody's lost any opportunity to kind of communicate with each other. So it's use of tools. It's really engaging patients and family caregivers in decision-making. We have about 20% of our patients that we're moving from, and Randy's and Aetna's programs in this regard, moving from the current way in which we care for them to better palliative care, and for some of these patients to better hospice or end-of-life care, but largely through a very active process of engaging and the patients through use of a variety of strategies. So I hope that answered your question. So is that? I want to make sure.
One quick question. There's no other. It's Barb. I'm curious how much treatment fidelity data you actually got in terms of things like you can get a horse to water, but making these folks drinks is not that easy. So many of the interventions you were doing were behavior change related issues.
Yeah. And
I'd just be curious what you were able to collect in that area.
Very little. I mean, what we have is the nurses would clearly as they pursued each intervention, would also talk about and document patient's response. Now, sometimes it was immediate response, pushback, et cetera, and often in the form of, a week later, 2 weeks later, et cetera. So much of what we documented was self-report and the associated outcomes, relevant outcomes. So if people were struggling a great deal in terms of symptom management, so for the knowledge that can they share back to us that they've written it, and then can they tell us a couple of weeks later, how it is that they're doing it. I mean, in different trials we use different things. We use patient diaries and so on. And ultimately relied on both a combination of self-report and the actual outcome that was of interest, and a nurse's own assessment. So how well did we achieve symptom status through real rigorous measurement of that? So I don't know that answered. I mean, I think that there's probably much more that we could do along those lines, but that's how we did it.
Yeah, that was sort of what I assumed, just was curious.
Right. Oh, well, 5 o'clock. So Randy and I want to thank you. You're a great audience, and we really, really, really enjoyed this opportunity to at least share a part of our story with you, and really, your questions were terrific. And so, Randy, any parting comments?
Thank you for sharing it.
Great.
Thank you.
It was great.
Thank you very much.
Great. Thank you all very, very much.
Okay.
Bye.
Bye.
Bye-bye now.
Thank you.